we're here today to talk about a different treatment approach to the human body that we have kind of discovered at our clinic through practicing over and over and over again, trying to get better and better at treating patients more quickly, better overall recovery, and just a complete rounded approach. And in this process of seeking this information, we think we found a better way. And that better way, to sum it up, is treating the spine first and foremost to treat basically almost any condition that can be present when a patient comes in. And we'll get into this more as we go. But I figured at first the listeners would want to know who I am and why they should listen to me. So my name is Caleb Knippenberg. I'm a physical therapist with 15 years experience, and I am an expert orthopedist, physical therapist. I don't use the word expert lightly because I feel like it's thrown around there too much. So when I say expert, I really do mean it. I have 4 advanced orthopedic certifications beyond my doctorate in the field of physical therapy, all aimed again at the orthopedic, where we have so many other avenues, pediatrics, women's health, inpatient, outpatient, neuro, acute, all these other that you could specialize in. And I've spent these past 15 years, aggressively pursuing advanced certifications in just the field of orthopedics. Beyond that, my wife is also a physical therapist who is an expert in her own right. This is not my wife who's here with us today, but my wife is an expert an expert physical therapist herself. She specializes in women's health, and she actually has certifications she has 2 certifications in women's health, 1 in geriatrics and 1 in orthopedics. So not only was I pursuing this information, but the person that I was going home to every single day was also pursuing this information, and it's almost all we had to talk about. And then finally, if that wasn't enough, my wife and I started our own business almost 8 years ago now. And in running our own business from the ground up, we had to be inundated day in and day out with this information. We spent 100-hour weeks at the clinic for years. We spent more time and effort than most people out there just thinking about physical therapy and how to treat our patients better, because that's what we wanted to build our business on, is the quality of treatment, the outcomes, rather than any superficial stuff. So to introduce who is with me here today, this is Rosina Strauss.
Yep. So I am one of the orthopedic physical therapists at Core 3 in our Hatfield location. I've been working at Core 3 now for 4.5 years, and I also have some advanced certifications, not as much as Caleb over here, but I have spent my career also specializing in orthopedics and having advanced degrees in that on top of my doctorate. So I'm very happy to be here today to discuss these things with you all.
Yeah, and what Rosie alluded to, Rosie was my intern for about 6 months, which is double the normal amount of time. And so while she was my intern, we were able to get deeper into advanced treatments. And then after that, she came to work for our clinic, Core 3 Physical Therapy, and she spent, again, her time more in a focused pursuit of orthopedics. So she has her orthopedic certified specialty degree, which only about 20% of physical therapists out there have a specialty degree. She also has her McKenzie certification, which is another advanced orthopedic certification in the field of evaluation and treatment of the spine specifically. And she is about to test for her third orthopedic certification that is primarily aimed at manual manipulations, mobilizations, and stuff like that. So again, when we say experts, we literally mean experts in our field. So what we want to talk about is the way that we are now treating, that we have seen better, more complete results than anybody else in our field, but even that in other fields as well, in other healthcare aspects of it. And we are not just treating the typical orthopedic conditions like shoulder pain, elbow pain, knee pain, although we are treating that as well. But we've also found that our approach is able to be applied to a vastly different diagnosis field, such as asthma, Crohn's, headaches, GI issues, Gerd, dizziness, and we'll get into more, and actually even into the women's health aspect of it, where our approach in treating the spine and evaluating the spine We've been able to cure testicular pain in patients. We help incontinence issues in patients, and we'll get into why this makes sense. But basically, us discovering this and applying it has had amazing results, and we feel we need to get this information out there. We feel it needs to become more of the gold standard of treatment, and that it needs to be applied throughout most aspects, if not all aspects of healthcare. And it also needs to be further evaluated, because we just missed this. We missed this in our field a while ago, and we started looking more granular and more molecular and more into our DNA, and we missed what was in front of us. We got tunnel visioned.
So let's go back to what is the traditional approach?
So the traditional approach is basically you come in and you have some type of pain, and they look, if you came into any physical therapist out there for the most part and you said my elbow hurts, they look at your elbow and they try to see how it's moving, they try to see where it's tight and stretch it, and they try to see where it's weak and strengthen it. And that's basically the approach. And that's all they have to do for you. They can rub you down a little bit. They can put some ice and some heat on it. They can put some stim and ultrasound and all this stuff that it feels nice, but it doesn't really get at the why of it. It just helps the symptoms. And our approach gets at the why. Our approach gets at the why did this happen in the first place? Where is it actually coming from? Where can we treat the cause in order to treat the symptoms?
So what you're saying is that traditional physical therapy has been symptom focused, not
traditional medicine in general has been symptom focused, which again is kind of why we're here. If you think about any of the treatments that you go and you get from your doctor, they give you let's just say a cortisone injection. And so it helps the local inflammation and it helps the pain, but it doesn't do anything to explain why it was there in the first place. It doesn't do anything to treat the why. It just makes you not feel your pain for the most part. Most pain management, most pain treatment is purely to numb your body to the sensation that it has in order for you to be able to move on throughout your day. If you get a pain injection, if you get pain medication, if you get a dermal patch, all of it is medication that just addresses the pain just at that site, but nothing explains why the pain was there in the first place, and nothing treats the why.
So basically what you're saying is, rather than looking at individual parts of the body and where the pain is, you guys have gone back to looking at it as a whole, like as a system, rather than just
as a system. We do look at the body part. I don't want it to sound like we don't.
Yeah, no.
If you come in and you said elbow pain, we first look at your elbow. Because we want to map out how your elbow is doing. We want to map out how much it's moving, how much it hurts, where it's not moving. We want to basically delineate your symptoms, and then we move on to the corresponding area of your spine, and we see if there's a problem there. And more often than not, if I'd say like 97% of the time, there is a problem there, so we treat that problem. If it's that part of your spine's not moving well, that part of your spine is painful, we work on it, we show you how to work on it, and then we retest in that same visit how your elbow is, and we see if it changed. And if it does, then we know that there was a spinal component to your pain, and we treat both. We'll start with the spine and we'll see how far it'll take us, and often it takes us the entire way. Often we're able to treat your entire elbow condition, your golfer's elbow, your tennis elbow, just by working on that corresponding area of your spine, and we never had to treat your elbow because there wasn't a problem there in the first place. The problem was from the signal getting to your elbow.
So explain the signal getting to the elbow.
So we've used a lot of analogies, but one of them is like the internet. And I guess before we go to that, if we're talking about your elbow specifically, we've mapped out in history where your nerves emerge from your spine. So you have one central spinal you have your spinal cord, and out of their spinal cord, all these little branches come out and they run throughout your body. And we know where in your spine do those nerves go to where in your body. We've mapped that out, although there's an issue with that too, because the last time that we actually mapped that out was 1948. And we use
There's been no mapping of how the nervous system flows through the spine.
And you know what? I'll give this to Rosie, because she was the one that looked into this. I knew we were deficient or derelict in our are re-looking into this, and this is used throughout every aspect of medicine. Your massage therapist knows dermatomes and myotomes. Your orthopedist, your primary, your physical therapist knows dermatomes and myotomes, and they're taught it in school. So go ahead.
Yeah, so we're all taught it in school, but every textbook looks different in what this picture looks like. So the mapping of our nerves isn't going to look the same from one textbook to the other. So that does make it more difficult when you're trying to utilize it for treatment. But we were looking into when the last time it was mapped out, and it was 1948.
I think.
Yes, around that time. And then, someone else obviously came into the mix where there was two versions of it, and then they basically put the two versions on top of one another, and then where they overlapped is where that they kind of found the common ground and made the new dermatome map. And so it wasn't done via testing, it was just more taking the two versions, overlapping them, and seeing where they kind of coexist together, and then that's where the new one came out. And I believe that was done more recently than 1948. But
I think you said in the 70s there was a study, and then they looked into this again in like 2007.
2008.
2008.
Yeah. Yep.
And what they found was what you were saying.
Yeah, where they overlapped it.
So let me just be clear. So they've mapped it out, right?
Yes.
Like, meaning we've done full body scans. We know what it is.
Well, you say full body scans, but remember, this is 1948.
Right. But
Yeah.
so the newer one, did they do a full scan? Or are we talking about like they haven't?
No, they
No.
just took what had previously been done. They basically made the amalgam of they took, there was, let's just say 3 studies, and they put 1, 2, and 3, and where all those studies agreed, that's what they took, and then that's what became where it goes to. Which is insane, because again, we use this. Your neurosurgeon who literally operates on this area, this is what he studied in school, and like what Rosie said, it's different from textbook to textbook. It's different from school to school. You can go online and you can find 30,000 different ones of them, and you know how we're all different. We're all snowflakes. This is actually one of the areas where we're not that different. My C5 goes to my thumb. Right. My L2 goes to my thigh. Hers does, yours does, everybody else does. Sure, there's some variation, and there is actually some redundancy in our nerves too, where we have more than just one nerve that supplies an area.
So let's go back to, because you were saying you use the analogy of the internet, right? So I'm assuming that means that when everything's functioning, everything is full signal.
Everything's full signal, everything's working, you're streaming Netflix, and you're not getting any pausing whatsoever.
Okay. So if I'm understanding you correctly, what you're saying is there could be certain parts of the body where you have multiple nerves going to it. So you have your primary internet, but you have a backup internet that feeds a little bit of it.
Yeah, you know what, you have somebody on your Wi-Fi, and they could be doing some stuff, and it's affecting you, but maybe it's not. Yeah.
Okay. And so you guys look at all of those and say, okay, so it may not be the L2, but it could be, I'm just throwing numbers, like it could be number 8 that has a secondary signal that should be firing and it's not.
Right. And again, we're all pretty much the same. The outside of my elbow is somewhere around C5, C6, middle finger is C7, so, for your general knowledge. And what that means, C means cervical, so your cervical spine. And the next would be thoracic, your thoracic spine, then your lumbar spine, then your sacral spine. And we mapped this out, but when we mapped this out, again, it was 1948, which is a travesty. But we also didn't do it with the ability, or maybe even the foresight, of looking more internal, so into our intestines, into our liver, into our pancreas, our gallbladder. And we also did it with specifically like sensation, and I think it was primarily pain sensation, but pain actually has a bunch of different presentations. So like tickle. Like when you tickle somebody, it's actually perceived in your body as pain. It goes throughout the same part of your spinal cord up to your brain in the exact same way pain is. Tickle is pain. Pressure is pain. Tingling is pain. A stretch is a pain. Fullness. There's all these different symptoms that weren't even looked at, and again, different areas that weren't looked at and weren't able to be looked at. So we need to go back and we need to remap this out, because we can get better and we can have better treatment if we do. But for the example, somebody comes in and they say my elbow hurts, and I know it's somewhere in the cervical spine, where they're pointing to their elbow. So we map out how their elbow's moving, how much pain, and then we look to the cervical spine. But we're real broad when we do it. We do multiple levels above, multiple levels below, and we kind of give ourselves the ability to be surprised.